Dear friends, now we'll continue our presentations today. We'll talk about this devastating complication, eclampsia, and how to deal with this. Eclampsia can be defined to the occurrence of new onset, generalized tonic-clonic seizures or coma in a woman with preeclampsia. Epidemiology, it really depends on the developments of the country. In developed countries with high social income, the incidence is between 2 to 10 cases per 10,000 deliveries. In low and middle resource countries, the incidence may be 10 times higher. Eclampsia occurs in 3% of women with preeclampsia with severe features who are not receiving anti-seizures prophylaxis, and in up to 0.6% of women with preeclampsia without severe features. Timing: 60% of eclampsia occurred antepartum, of them 50% preterm and 30% between weeks 20 and 30. 20% occur in antepartum and 20% postpartum. Approximately 90% of postpartum seizures occurs within 1 week of the delivery. Clinical findings. So most women have symptoms in the hours before the initial seizures. More typical presentations may be hypertension in 75%, headache in 66%, visual disturbances in 27%, epigastric pain in 25%, and maybe asymptomatic in 25%. Ankle clonus is a very common feature. This analysis is performed on 21,000 women with eclampsia. The seizures themselves may be divided into two stages. The first is ictal phase, and the second one is post-ictal phase. So eclampsia is generally manifested by generalized tonic-clonic seizures or coma. Abrupt loss of consciousness often associated with a scream or shriek. Muscle stiffness, cyanosis. After approximately 1 minute of tonus, the muscles begin to jerk and twitch for additional 1-2 minutes. In the post-ictal phase, the women are usually in deep sleep, breathing deeply, and then gradually waking up, often complaining of headache. Most patients begin to recover within 10 to 20 minutes after the generalized convulsion. Focal neurological deficits are generally absent. Fetal monitor pattern is very typical. During the convulsion itself, we usually can see fetal bradycardia lasting for 3-10 minutes as a result of hypoxia and elevated vagal tonus. After resolution of maternal seizure, activity is associated with fetal tachycardia, loss of fetal heart rate variability, and transit decelerations. It's very interesting and important to consider that recurrent deceleration for more than 15 minutes despite maternal and fetal resuscitative interventions suggests the possibility of occult abruption of placenta. Eclampsia is a clinical diagnosis based on the occurrence of new onset topic clonic focal or multifocal seizures in the absence of epilepsy, stroke, drugs. You mean different reason for that. Typically in women with hypertensive disorder of pregnancy like preeclampsia or gestational hypertension. When we are talking about DD seizures with persistent neurological deficit, suggest an anatomical abnormality may be related to stroke, intracranial hemorrhage, brain mass lesion, thrombotic thrombocytopenic purpura. And seizures without neurological deficit may be both typical for metabolic abnormalities like hypokalemia, hyponatremia, and hypoglycemia, drugs and toxins, and infections like meningitis, encephalitis, sepsis, whatever. Management. Actually, management may be divided into 4 different groups that could be started simultaneously, but in order to make it academically reasonable and convenient, we'll discuss each one separately. Okay, they include prevention of maternal hypoxia and trauma, treatment of severe hypertension, prevention of recurrent seizures, and evaluation for prompt delivery. Maternal oxygenation is extremely important. Women should be placed in lateral position. 100% oxygen mask should be applied, and women should be protected from trauma during the convulsion. Yeah. Treatment of hypertension. First of all, risk of stroke is in close correlation with degree of elevation of blood pressure and maternal age. It's not clear what is the threshold pressure above which the therapy should be started in pregnant hypertensive women, but most common recommendation is to start antihypertensive therapy when diastolic blood pressure is higher than 105 millimeter hydrargyrum, or systolic blood pressure is higher than 160 millimeter hydrargyrum. Prevention of, by the way, it's important to know that labetalol and hydralazine are equally effective. As a rule of thumb, hydralazine may be preserved for the cases with maternal bradycardia, and labetalol for the cases with maternal tachycardia. Well, prevention of current seizures. For this reason, we can use anticonvulsive drugs and the magnesium sulfate. Magnesium sulfate is a treatment of choice and is very effective in treatment of seizures. One should consider that actually length of convulsions is pretty short, about 3-4 minutes, as we said. Okay, so magnesium sulfate is not as effective for treatment of specific convulsive event, but rather for prevention of ongoing additional convulsions. Okay, so magnesium is a drug of choice, as I said, and it is capable of reducing the rate of recurrent seizures by 50% and risk of maternal death by 30%. Magnesium sulfate was shown to be safer and more effective than phenytoin, diazepam, and chlorpromazine for prevention of recurrent seizures in eclampsia. Administration, 4 to 6 gram over 20 minutes IV, okay, with maintenance dose of 1-3 gram per hour, and following repeated clinical examinations and measurements of magnesium level in patient's plasma. Well, for the patients with renal dysfunction, levels of magnesium should be closely monitored and doses should be significantly reduced. Actually, for renal insufficiency, when creatinine level is above 1.5 milligram per deciliter, And when urine output is less than 20 milliliter per hour, it's recommended to recheck magnesium level in 6 hours and stop magnesium maintenance until we receive levels of magnesium in plasma. When serum creatinine is between 1 and 1.5 milligram per deciliter and the urine output is adequate, it's recommended to decrease infusion rate twice and maintain it lower than 1 gram per hour. And again, a magnesium level should be rechecked in 6 hours after the first administration. Okay. Calcium gluconate may be effective for preventing magnesium toxicity if it's necessary and the patient develops magnesium toxicity. Magnesium is contraindicated in myasthenia gravis because it may precipitate a severe myasthenic crisis. The optimal duration of magnesium therapy is 24-48 hours postpartum. Management of recurrent seizures may include additional bolus of magnesium sulfate when it's necessary, and increase of magnesium maintenance simultaneously. Recurrent seizures while on magnesium seizure prophylaxis is susceptible of stroke. About the delivery, as you know, the delivery is a definitive treatment for eclampsia, and it's absolutely necessary to perform. The major concerns associated with general anesthesia are difficult intubation because of oropharyngeal edema, transit spike of blood pressure during intubation with possible intracerebral hemorrhage, and anesthetic-induced hypertension. Neuraxial technique may be generally safe and effective in women with preeclampsia. Two concerns with use of neuraxial techniques are potential for significant drop in blood pressure and peridural hematoma in women with severe thrombocytopenia. Thank you very much for your attention. I very hope to see you soon alive after your win in the war. See you.